So hi everyone. As David mentioned, I'm from the University of Calgary. I'm an assistant professor in the School of Medicine in the O'Brien Institute for Public Health. And I do public health policy science and also prevention and education research around harm prevention, harm reduction for cannabis use amongst youth. So I'm very happy to come here and talk to you today about what is the public health approach to cannabis, which is embedded in our current legislation. What do you need to know about that? You may be having debates with people from your roles. You know, legalization won't protect public health. This is going to be horrible for our country. I hope that through my talk, I can give you the skills to engage in this discourse, which has been very polarizing in the cannabis policy space. Okay, so here's a little bit to know about me. I'm a little bit of an anomaly in this research science space because I've been advocating for the lowest age possible for youth access based on these public health principles, that this is the best option to protect youth by allowing them access to the regulated market, recognizing that youth are the largest group demographically consuming, right? So what is the policy context in Canada that led to our public health approach to legalization and regulation? Well, we know that in the past, cannabis policies have not been based on any evidence from public health about what the substance is, how it's used, how many people are using it, and what the harms and benefits are. It's been largely based on values of just say no to drugs and keep the substance illegal. We had recommendations in 1972, the year that I was born, from the Ledane Commission, recommending decriminalizing cannabis. This has been suggested by best practice evidence for so many years now, and we haven't acted on it because we have values around keeping it illegal. The evidence from clinical science on the health risks and benefits is still developing, but that's not really what's been factored into a lot of the decision making. We also know that most of what we do around the education and prevention for youth has not been based on good, solid evidence. It's been based on these principles of abstinence and just saying no, and all substance use is harmful and all cannabis use is harmful, which is quite frankly not been effective at all when you look at our numbers. We have the highest rates of use amongst youth in the developing world, right? The World Health Organization Health School Behavior Study shows we have 30% of kids 15 plus using. So absolutely the model we have has not done anything helpful in that regard. So there is a need for a coordinated public health approach, and I feel like this is what is embedded in our legislation, and that's what's going to be helping us going forward. So what is a public health approach to cannabis? If you're not a public health scientist, if you don't work in academia like me, if you don't work in policy science and government, this may be foreign to you. And you'll hear a lot of debate. As this bill moves through the Senate, there's a lot of debate around this right now. Well, legalizing won't protect public health. We're going to have worsening outcomes at the population. Like, what is government thinking? This is a poor decision. On the other hand, the public health rationale embeds these principles. And these are as follows. We're recognizing that people use substances for their beneficial effects, that drugs are used culturally, socially, that they're embedded in our social context, and that they have benefits to users. This is quite different from a medical model of approach, which only looks at the harms and negatives associated with use. So that's where a public health approach differs, number one. The second thing is that we're looking at the unintended consequences or the negative policy consequences of keeping something illegal. And in that case, it's prohibition and criminalization of cannabis, which has absolutely been harmful to the population. And so in this space, we're looking to balance the harms of the criminalization policy versus the harms, the intended or the supposed public health harms, right? So I always say the harms of prohibition are not abstract. They're actually quite tangible. To give a more concrete example, if I'm somebody who's had, and I'm one of over 500,000 plus Canadians with a criminal record for possession, right? That's not an insignificant statistic. So if I'm a member of this group, I can't get a clean police check to volunteer at my kid's preschool, can't coach community soccer, can't work with vulnerable people. This has absolutely been a failure. It's not a benign consequence to have a criminal record. It's something that follows you, prevents your travel and your work. So this is what has gone into our health science, public health science model, and saying the harms of prohibition have definitely had a negative consequence for our population. We need to make a bold policy move because the model that we've had right now has absolutely done nothing around protection and deterring use when we have the highest rates of use amongst youth in the developed world. So my colleagues from the Center for Addiction and Mental Health drafted this cannabis and public health framework in 2014, and it's actually the approach to legalization with strict regulation that's very much embedded in the report from our federal task force that came out in 2016. And I was very happy to be at the Alberta Roundtable when the federal task force came to Edmonton to talk to us here as scientists and stakeholders about what we wanted to see in the legislation. And my colleagues are very clear that when we talk about the health of the public, if you're not already getting this point from what I'm saying, is that it's not only about protection. And reviewing the evidence of different psychoactive substances and health practices, they actually make the case that there's really good epidemiological evidence right now that hockey is quite harmful to youth brains because of, you know, the blows to the head. But we don't make hockey illegal, and we don't say you have to be 25 plus to participate in hockey. We very tightly regulate the rules and restrictions around how people engage in hockey, especially around youth, and we mandate that people take steps to lower their risks through wearing helmets and preventing fights and other measures. And if we actually looked at the population level data on harms, well, quite frankly, we'd make alcohol and tobacco illegal at this point because of the harms that they do to the population. Thanks. So just to recap, from a policy lens, what we know in Canada is that prohibition has been a failure. Illegal status has not deterred use, so that's the one indicator of an unsuccessful policy. Our supply in the illicit markets, not speaking to the licensed producer and medical context we have right now, but the supply in illicit recreational use that people access is unregulated. I've outlined that criminalization has real intangible harms for our population. And overall, the harms of cannabis compared to other psychoactive substances that are legal are quite smaller and lesser. So I'm a scientist, so I'm going to show you some graphs, because that's what we like to do. So the prevalence of use among Canadians, if you weren't aware of this, the tallest graph is people who report ever using. So that's lifetime. You used it once in your life, you're captured in this. And then the next one is the past 12 months, and then we go on down to past 30 days, and then to daily use. So what you can see in that our population reported use here, the largest group of users are youth aged 20 to 24. And then once people go into the age 25 category, use tends to taper off. Now this is what's reported to Stats Canada in our large data collection. But even in the course of the last 2 years, as we move towards legalization and we have new surveys, we're seeing even higher numbers. And that may not be because there's actually higher use, but what I think is that, and what colleagues in population health know, is that people are less likely to report their use to government surveys, right? So now that we're legalizing and destigmatizing and normalizing more and more people, we're going to see rates go up at the population level, and that's maybe because people are more open in sharing their use. Because we're in the Alberta context, I also wanted to show you the data around how youth are using. And you can see that on average, just as of 2 years ago, youth are using a little bit less than other youth. And this idea that, that youth are very much at risk, you see that most youth is represented in the ever use category, right? There's a very, very small percentage, that's 2% for Canada and 1.4% for Alberta, of youth who use frequently or daily. So the idea that there's this epidemic of kids using every day, all day, is just not borne out by the data. And then one thing that I think really opens people's eyes when they're thinking about, well, what is this context for protecting vulnerable people in our population, and especially youth, is that over the past decade, cannabis use amongst youth has actually been significantly declining. It's almost halved, right? But you can see other substances on this chart, including alcohol and other pharmaceuticals, have more or less remained stable. However, if I didn't make my point abundantly clear how I feel about prohibition and criminalization, one thing that's not been declining enough is the arrests for possession. So if you look up top, that first green box I have are the arrest rates for possession from the StatsCan data up to 2016. And some of you know this quite well, that even as our government was elected and we're moving towards legalization, in 2016, we still have 44,000 Canadians arrested for simple possession. That's not trafficking, that's not intent to distribute or sell. And to me, that's just unacceptable as we're moving into this realm of legalization. So to make my point again about cannabis harms as being far lesser than other psychoactive substances, there's a really well-known study from a medical journal called The Lancet by David Nutt and colleagues. And in this study, they mobilized a group of policy scientists, researchers, and experts to talk about the harms to individuals and the social harms of various psychoactive substances. And again, you can see that cannabis, out of a scale of 100, received quite a low ranking at 20 in terms of the harms, the health effects for individual users, and what they call social harms in terms of public aggression and violence, domestic violence, motor vehicle accidents, right? So not surprisingly, the substance with the highest score is alcohol at 72. So when we're trying to design policies that balance these social and health harms and optimal public outcomes, this is one of the most frequently used illustrations that we try and communicate what the public health approach is. And it's in that sweet spot at the bottom of the curve, somewhere in the middle between the illegal market and having criminalized the substance, and then totally unfettered corporate model, right? So down at the bottom, you see that de facto decriminalization is there. And in some policy contexts right now in Canada, we might argue that we have that. But why de facto decriminalization is not optimal for public health and equity is that it leads to a lot of bias. So another analogy I use is that if I'm with my colleagues from the U of C and we're smoking a joint on the porch before a party, police might roll by and say, hey guys, Dr. Saw and company put that out. However, if you're like my nephew, who's an 18-year-old black youth in Toronto, you'll have a record for possession when you're 18, which is actually, what's happening in my own family, which is unfortunate and absolutely linked to bias, right, when we have de facto decriminalization. So just again to show you the illustration of how these public health principles and rationale to allowing legal access and minimizing harm are very much embedded in the federal legislation and in the report from the task force. But they're also embedded in the Canadian Public Health Association, which is an association I work with most frequently as a scientist, in their approach to psychoactive substance use and cannabis legalization, but most importantly, recognizing that people use substances for a range of reasons, that there's many beneficial reasons why people use substances. We're not focused solely on harms. And that when people have very problematic use, often this is tied to other underlying individual social community factors such as trauma, poverty, and inequity. So finally, the last thing I want to share with you is the lower risk cannabis use guidelines that are also being advanced through this idea of public health. The lower risk use guidelines have been endorsed by many organizations, including the Canadian Public Health Association, the Canadian Psychiatric Association, the Centre for Addiction and Mental Health, and Canada's Medical Officers of Health and Principles. So these are all the leading organizations that are concerned with public health in Canada. And they're developed by a network that I'm a part of called CRISM, which is a Canadian Research Initiative in Substance Misuse. And they're a starting point. I know they're not going to sit well with all of you, but this is a starting point of talking points to say to people. You know, I talk to parents, I talk to youth, I talk to health professionals, and they're just not initiated into the range of ways of using cannabis and the fact that there's safer ways to use cannabis if you're going to use. And this idea that there's behavioral principles and ways of changing your use that can make it less harmful over time. So I think these are a really great starting point, and I wanted to point these out to all of you that are there when people say, you know, this could be a negative thing. And I realize that that's not the audience I'm speaking here today, but most frequently when I talk to health professionals, it's kind of like mind blown. Oh yeah, there's harm reduction that we can do in cannabis that will protect people's health effects, and there's safer ways of using that we can recommend to people. So on that note, I'll close, and I'm very happy to take questions about the lower risk guidelines or other public health issues that you want to chat about.
Thank you, Rebecca. I see you have a question here. I just want to make sure we have enough time for everyone. So if someone else has a question, just put your hand up and I will slowly get to everyone.
Hi. What are your thoughts about AHS's proposed guidelines for cannabis? Because they're pretty stringent.
Okay, so you mean in terms of the medical space or in terms of the model that they're recommending?
In terms of the model that they're recommending.
Yeah, I think that health authorities are always going to take the most cautious approach. I would say that, you know, on the one hand, from other work I do in substance use, we're seeing a scaling up of harm reduction for opioids and injectable drugs. And so I'm hoping that somewhere we coalesce in the middle and people recognize that harm reduction and risk reduction, lower risk guidelines are also appropriate for cannabis. But thank you for pointing that out. Yeah. Mm-hmm.
In the medical space, we hear a lot about the impact on youth's brains, the growing brain. Can you talk a little bit about that impact of harm on children I guess, brain development below the age of 25?
Yeah. So this is the most frequent thing that's cited in the research, and when the medical associations come out and say, no, like this is going to be a disaster for public health. I think one of the points is that some of the research has been overplayed and has been inconclusive. The safe answer that we give in a health and medical space is that, you know, the research is still developing. We know enough to say if you start very early with use and you use very frequently, and that's embedded in these guidelines, then the more likely you're going to progress to a problematic trajectory of use, right? But this is kind of basic for any substance. And when I talk about early use, I'm talking about pre-15. So if you're starting to use substances at 13, and you're using frequently and daily, there's definitely other things going on in your life that are not specific to the harms of cannabis. So what I like to say is, yes, it could be risky for use, but the risk is not equally distributed. So we need to think about those vulnerable groups in terms of poverty, violence, generational trauma. Those are the risky spots that we need to intervene around youth and cannabis. But a youth who's using it at a party recreationally, you know, once a month, like this, it's not the same risk for everybody.
And on that same topic, do you think that there's any sort of other data collection sort of misrepresentations? I know you mentioned earlier the people being sort of ashamed to admit their use, maybe in the 25 and older categories. But anything else that it points out there that you could find comes up in arguments or debates?
things that are being misrepresented in the debates? Well, there's lots of lots of not understanding the public health rationale is the biggest one for me that kind of irks me. And we see these statements all the time that focusing on to protect public health, we need to protect young brains. It gets me very angry as someone who's oriented to public health and social justice. Like, I wish people were as worried about protecting young brains from poverty and violence, but it seems that because cannabis is a discrete substance that we can intervene on, that's what most people focus on. But there's many other things, including alcohol, that are very risky to young brains. But these are legal and culturally acceptable as a rite of passage for youth. And the evidence shows probably more harmful, right? So that's the real misrepresentation that upsets me the most, yeah.
Does anyone else have any questions? Well, in the meantime, I have a question. Could you talk a little bit about, so, you know, in the Senate, in the House, and in conversations we hear different people referring to different statistics out there in terms of legalization affecting youth use rates, and general public rates. And I'm wondering if you could talk about the discrepancy in the data that's out there, because we see, you know, we see references to, there's information showing youth use has gone up in Colorado.
Yeah.
Then a month later, there's a headline saying that actually it's gone down or it's stayed the same. So can you talk about that information and what we do and don't know?
Yeah, I think the population level statistics can be distorted depending on what your stance is. You know, we had a Cannabis and Public Health Forum here in May, and we had Bo Kilmer from the RAND Corporation who looks at this data across the U.S., and he kind of made the point that, like, whatever your stance is, pro or con legalization, you can find a population level survey that supports your point. So when you're looking at those stats and you're citing those stats, I would say interpret with caution. A lot of it, when rates are low, has to do with collecting data in schools or in other contexts where the people who are collecting data are a government authority and people are less likely to report use. However, you know, the other thing to focus on when we think about, prevalence has gone up or prevalence has gone down, is from a public health approach. I'm actually not panicked about prevalence going up, right? If more people use, that is not necessarily harmful. What I'm thinking about, if I want to, you know, be cautious around the policy consequences, is what is that pocket of use for a vulnerable person that's using very intensely or frequently or daily, right? But general population elevation of use, I don't see a reason to panic about that in the statistics. Yeah.
Thank you.
Yeah.
Does anyone else have one? We probably have time for one more question. Is there one more question in the audience here? Okay, well, let's have a round of applause for Rebecca.